We're live. Ta-da. Here we are. Welcome to Tales from the Heart, a podcast from the HCMA. In this experts edition, we are joined by Dr. Patient Alex Feria from University of Pennsylvania. Good morning, Alex.
Good morning.
I love giving you your titles when you come to podcast with us. It's
I
fun.
love it when you give them. Appreciate that.
Great. So I have a couple of announcements before we get started today. And then we're going to dive into some really great conversations about getting ready for your year with HCM, as well as getting ready for Heart Month. So we have some fun art to share with you today. Um, Believe it or not, in a few short days, a few things will come to pass. Number one, the HCMA began its work in the fall of 1995, and we formalized our submission for 501c3 status. We formalized our submission in February of 1996. You actually don't find out if you get it or not for a while, so we were already doing work for a year and a half before we had officially gotten our paperwork back. But we will be entering our 30th year of operation on February 1st, technically and legally. So we are here in our 30th year of operation. And on February 2nd, I will celebrate 9 years with a transplanted heart. That went fast. And on February 25th, we will have HCM Awareness Day. So we have so much coming up in February, a lot of milestone celebrations this year. Stay tuned for updates on our events. We're going to have an in-person event here in our New Jersey office. If you're in the area, come on by. You'll learn about our work, have a little fun, have a little food, have a little conversation, and learn how you can get involved. So you can sign up now, and that evening we'll be holding a webinar. Appointments are not appointments, but you can register now. That's the word I'm looking for. And we'll be talking about all the milestones that have happened in HCM over the past 30 years. It's only going to be an hour and a half conversation. We're going to kind of go fast, but we're going to be dropping content all through the month of February for Heart Month on patient stories, on advances in medicine, on legislative briefings. So stick with us through the month of February. It will be a very eventful time, and my team is ready for it. So it's going to be cool. We have 7 legislative briefings through the month. We've got a couple of bills that are going to be dropped for the Children's Cardiac Safety Act throughout the country. And it's been a little crazy out there in the world. And to see some positive momentum in the space of checking our children's hearts and our families' hearts has been a little bit of bright light out there because we're really starting to make some traction. And in fact, in 2026, we'll be partnering with the American Heart Association to pass laws in about 7 to 10 states. So if you're interested in getting involved in those efforts, do contact the office and Julie can align you. Tomorrow, we'll be having a podcast to talk solely about gene therapy. And we are going to bring back to the stage the first patient dosed with gene therapy. And her name is Julia, and she's amazing. We did a podcast with her when we were in New Orleans, but the acoustics were terrible. So we're bringing her back here, and you're going to hear her story, and Dr. Desai will be with us. And then you will also hear directly from the company sponsoring that trial, and you're going to hear a little bit about the science. And that's tomorrow morning at 11 live. You're welcome to ask questions during that session. So that's what's coming up. Alex, what is the coolest thing that you think is coming up or you've seen written about over the past couple weeks since last we spoke?
Yeah,
What's
I
going
know
on?
that well, first of all, so many things have happened in the last year
Yes.
that, and you're so on top of it that when I brought up ideas, you're like, oh, we're talking about that tomorrow, or we're talking about it the next day. But the gene therapy stuff is incredible. I had the pleasure of meeting Julie, and kudos to her. A lot of women that decided to do that trial. So it kind of shows their strength, and a population in HCM that is diagnosed late and a lot of times sicker. So,
Yeah.
but the gene therapy is incredible. I mean, there's multiple things published this year about the real world experience for instance, for mavacamten. Like there was a time where a lot of people were very worried about what mavacamten would do to people with HCM. Was it going to be helpful? There was even editorials written about, oh, could this be harmful?
Right.
And to have gone from, the basic science work in animals to clinical trials to humans and then FDA approval. And now we're going on 4 years. I think is it right? In April, it'll be 4 years.
April 22. Yeah.
And so, our group has helped publish real world data on these drugs, and it's been incredibly safe. And so to go that full spectrum, some of those papers have been really interesting and have changed the way that everyone thinks about how we treat this disease.
I think the other backdrop that's happened since last week or in the past 2 weeks, I think we talked about it last week briefly, the SCOUT data, the top line data has been released by BMS. So SCOUT is mavacamten in adolescents, so 12 to 17 years old. And the top line data is showing it's tracking with adults and it's looking very favorable. So we might be looking at a label sometime in the next year or so for kids.
Yeah, which is incredible because, I can speak to this. Some of these meds that we put people on as adults when you're a kid, beta blockers are not fun. And so, to be able to offer something else to kids is incredible. And I also think now that we get more data on the populations that we're used to treating, we can start to think about other populations that we've been more hesitant to treat. So for instance, patients in the adult side, patients that are asymptomatic but have obstruction, like, Milind Desai, who'll be joining you tomorrow, they had a good paper out of the Cleveland Clinic looking at how do people that are asymptomatic do. And, and I run through this every once in a while. I have patients that have severe obstruction. They say they feel fine. I put them on the treadmill and they actually do quite well. And I think what we're starting to see is that the outcomes aren't as good as if there are some bad outcomes, and we might start thinking about treating people that maybe don't have full-blown symptoms, but have issues in terms of obstruction or other things in their heart that they will benefit from getting rid of those. And within that population, we'll find out that people probably did have symptoms that didn't realize it. But I think we're going to start to think differently at some point based on people that are saying they're asymptomatic. And then with the SCOUT trial, I think the next step is going to be thinking, well, what do we do for these kiddos that have genetic risk factors and are starting to show very subtle signs of disease? Should we consider doing something for them ahead of time? Maybe a lower dose of a myosin inhibitor to see if just decreasing how hard their heart is working from the very beginning could interrupt the cascade of what happens down the road. So I think that there's a lot of thought-provoking ideas that are going to be coming out of the data we have now. So it's just an incredible year of growth, and it keeps getting more interesting every year.
There are so many rabbit holes that you and I could jump into, but you've led me to one. So hang on, buddy, we're going in. You said whether they know they have symptoms or not. Okay. So there are times where I think it is incredibly helpful to have physicians with lived experience, because it's easy to listen to a patient and think it's something, but when you've lived it and you understand the subtleties, I think you're just that little bit more in tune with it. We don't really fully appreciate symptoms in HCM because they come on slowly and we think they're normal. Can you talk about your lived experience a little bit with symptoms and recognizing what was a symptom, but only after the fact?
Yeah. I mean, I think it goes to the point where you said, like, not knowing what it feels like to feel normal then gives you this false sense of what you feel is normal. And so whether it's you're a young kid and I used to play a lot of soccer, and you were always felt like you had to work harder than everybody else to do the same things, whether it was running or whatever, or even like subtle things like, oh, it's probably heartburn is why I feel bad after I eat a heavy meal every time, like my chest is tight. And so there's so many different symptoms that we experience that we don't know to attribute to this condition, that many physicians don't know to attribute to this condition. And unfortunately, because of that, patients are told quite frequently that their symptoms are likely something else. Could be psychiatric, like, the whole gambit of misdiagnosis.
Athletically induced asthma. It's
Yeah.
just an innocent murmur. They're
Yep.
just palpitations. Don't worry about it. Everybody gets short of breath when they walk up a flight of stairs. But do
Yeah.
that?
Yeah. And it's interesting because, in my younger patients, a lot of times you pick that stuff up because, like, most 15-year-olds are not going to get short of breath after a flight of stairs. But now as you add obesity into the younger populations, or if you look at the older populations, I have plenty of patients that say, well, I thought it was just because I was 50. And I was like, no, it's not.
No.
Most 50-year-olds. And then I asked them, I was like, so whenever you go out with your friends and you're all going up a flight of stairs, do they have to stop? And they're like, no, but I just assumed it was because I'm out of shape or blah, blah, blah. Like, so we can all kind of make, excuses in our own mind. And part of that is probably a protective mechanism. Like, I don't want to think I have a problem with this, and being scared to go to the doctor and be told, oh, this is probably because of your condition. Like, there is, especially in young people, and I had this too, not wanting to admit that there's something wrong. But there is something liberating, I think, once you realize that you're not crazy, like that this is real, what I'm feeling is real. And even more liberating is when it gets treated. You're like, oh my gosh, I can't believe I lived with that for so long and could have done something. And we're getting to the point where, at least with obstructive HCM, there aren't many instances where you should have to live with obstructive symptoms anymore. Like, there are ways to treat the obstruction, get rid of those symptoms. There's all kinds of other things that can cause symptoms too. But if you're sitting there with severe obstruction and you get short of breath, or you feel bad after a meal, or you can't walk up an incline, many, many times we can improve that significantly.
When you and I were diagnosed, which were many years apart from each other, but still what seems like in the dark ages of HCM, it was beta blockers, calcium channel blockers, surgery, device, have a nice day. That was pretty much the playbook. And there was the AFib playbook always. But today, 2026, that toolbox is awfully full. Always
Yeah.
room for more. So the role of myosin inhibitors in our sphere is really game changing. It really does offer a whole different way of looking at therapeutic pathways for people with HCM.
Yeah.
And it's when you hit milestone years, you have a tendency to really evaluate how you got to where you are, right? So where were we 30 years ago?
Yeah. I mean,
No one much. And I had already been diagnosed for 15 years at that point.
Yeah, I was diagnosed in 2002-ish. And so, yeah, I mean, it's totally different today. And for me, I had experience as a patient and as a trainee in 4 or 5 different centers in my life before I arrived at where I am today.
I love watching your education and career path. It's like center of excellence, center of excellence, center of excellence.
Yeah. And so the fortune that I had was that right when I finished my training, mavacamten was FDA approved 2 months before I became an attending physician at Penn. So, like, I didn't have to really rework the way I think about standard therapy for patients on my own, because it was fresh right when I hit the ground running, and I had been involved in the clinical trials beforehand. And so yeah, I mean, it used to be pretty daunting for patients to be like, okay, time for surgery. That's really all we have to offer here. That's been a huge change.
Very much so. So as a good pivot point to the next part of our conversation, and that is, what do we do every year as we evaluate our own health as patients, and what our pathway for our care model should be for the next year? This year, we have some added factors at play behind the scenes. And that's the question of healthcare access for some. And we know things are going to get complicated before they get better. So, in light of the current state of affairs and in light of the advancing understanding of HCM and therapeutic pathways, what do you think a patient with HCM should be planning to do for their heart this year? The way I look at it is if we sit down and we say, okay, here's my heart plan for the year. I need to have these tests done. Here's when I can do it. Let's get them scheduled. And when I get the results of those tests, then I can determine what my path is forward. That's the way I look at my heart health, even like without HCM, but being a transplant. What do you like to see your patients stop and think about? And what do you think about personally?
Yeah, and I think that part of it is thinking about the access, like you mentioned. I know you said you were going to bring Charlene Day, my colleague, on to talk about access in different populations and how easy is it for them to get access to care. So
Yep.
that's probably the first area you have to think about. And in their recent paper showing that people that come from lower income places have a harder time getting into specialty care. They have a higher rate of having heart failure symptoms because of that, probably.
Yep.
And that paper is looking at patients that go to academic centers. Like that's
Right.
the share registry. That even that alone is biased towards people that can even get there.
It
Most of
very
our
much is.
patients can't get there. And so I think if you have HCM, if you have a known diagnosis of HCM, if you can get to a center of excellence, great. There is a lot, and I tell all my patients to go through to the HCMA's website to look at kind of the care pathways that we have listed on here. Watch some of the podcasts to think about these are the things that I should be getting every year. These are the things that should be done if I have AFib. These are the things that should be done if I have, obstruction. Because if you don't have access to the centers, sometimes you don't get the routine care that you should. And unfortunately, then it comes to self-advocacy, which a lot of our patients are great about that. But
Yes, they are.
you should be getting a monitor most years to make sure you're not having abnormal heart rhythms, because maybe those days that you have really bad days, like a lot of us do, maybe you're an AFib, an abnormal heart rhythm from the top chambers of the heart. So you should be getting monitors every year, and doctors should be reassessing your risk for having a complication of this condition, whether it's an abnormal heart rhythm that puts you at risk for dying suddenly, whether it's an MRI every 3 to 5 years to make sure that there's no changes in the structure or the scar burden in your heart that could increase your risk. I put my patients on a treadmill every once in a while, every couple of years. I do a treadmill every other year, and that is to make sure that your exercise capacity isn't going down, even though you might think you feel fine. We're all really good at working around our limitations. So like, oh, I feel great, but I haven't gone up a flight of stairs in a year. Like the treadmill doesn't lie. So we do those things to make sure that we're staying on top of you so that you don't have to worry about yourself. That's one of the things I try and tell patients when they leave, because there's so much anxiety, like worrying about all these things you have to do, and then worrying about your family members that could have this. So I try, and we have a set schedule. I tell them every year, this is what it's going to look like for the next 5 years. We're going to do a monitor every year, unless you have an ICD. We're going to do an echo every year. We're going to do another MRI in maybe 3 to 5 years. We go through these things so that my goal is to take the pressure off of them. I say, let me worry about you. And so there are some very like guideline-based things that patients should be getting every year. That's more of the medical side, what the doctors should be helping you do. On a personal side, everyone has some sort of New Year's resolution, whether it's to exercise more, whether it's to eat less, find a
Eat
way,
better.
or eat better. In my case, both. And so, all of my patients, and myself included, will say that if you are routinely more active in some way, and it doesn't have to be going to the gym and jumping on a treadmill, and it could be walking down the street with your dog, or doing something to get your heart rate up a little bit every day, you will feel better. And so finding a way to incorporate some level of activity, like 30 minutes a day, if you can. If you can't, because you don't feel good enough to do that, then you should be talking to your doctor about that.
Absolutely. Everybody should, with HCM, should be able to do moderate activity for 20 to 30 minutes a day. And if you are unable to achieve that, that is a really important conversation to have with your team. It could be a tweaking of your medication. I don't want everybody to think, well, if I tell them this, they're going to tell me to go do something scary, like have surgery or a transplant. It's often a tweak of meds
Mhm.
and an evaluation of sleep patterns and diet and taking a moment to be thoughtful about how are you treating this thing that you have to go through life with.
Yeah. And
They're a little
sometimes,
complicated sometimes.
yeah, and sometimes there's things we can do to help you reach your goals, right? Like I have plenty of patients that have felt limited, and because of that, and they hadn't been treated before they established care. And because of that, they never exercised. So then they gained weight, and then they couldn't exercise because they still felt bad. So the weight kind of spiraled. And it's very hard to reverse all of that. But, in my clinics, starting myosin inhibitors and trying to help them out by starting one of these weight loss medicines like GLP-1s, some patients have had a lot of success with that. So
Yes.
just having these discussions with your provider, you should not be scared to tell your doctor.
No, but sometimes us telling our doctors these things that are our internal insecurities, I can't control my weight. I must be doing something wrong. It's all on me. I can't get any help for this because I should blame myself. Not a real healthy way to live.
Mm-mm.
And there are ways that you can make changes for yourself and have your team help you. I was insulin resistant most of my life, and I didn't know what that even meant. So my A1C was always good, but I was insulin resistant and I wasn't processing sugars properly. A little drop of metformin, and I dropped like 9 pounds because my body is processing sugars more effectively now. So have the conversations. There might be simple fixes that might help you get to the goals that you're trying to get to, but don't be afraid to ask. We got to talk about it. One
Yeah.
of the can HCM patients take GLPs? You want to talk
Yeah.
about that? By the
Yeah.
way, our new bubbles on the bottom got much bigger, and I didn't know that happened. So they're really big
Good.
today, and that helps my bad eyes. So go ahead, GLP-1s, Alex.
I have multiple patients that have struggled to lose weight. My brother was one of them. I'm convinced that if I could have helped my brother with something with a GLP-1 and helping him that way, that he probably would have lived longer. And so I have plenty of patients. I had this discussion the very first time I meet them. I was like, half of this battle is treating the HCM. The other half is treating everything that's happened to you because of side effects of the HCM or things that we've done to you. Like you can't exercise is what we told you for 20 years. And so in terms of the weight, I have plenty of patients that I've started concomitantly GLP-1 and myosin inhibitor and watched their lives completely change over the course of 6 months. Like get
Amazing.
rid of the obstruction, drop 30, 40 pounds, and feel like they've never felt before. I'm talking about some patients that were diagnosed as children, as infants, even. I have one that has not felt good their whole life to then have such a dramatic change. So I use GLP-1s all the time. I wanted to do a trial in GLP-1s and HCM. I think we got very close and something happened with it and it didn't happen. But I am sure that, and I bet you people even have improvement in symptoms with significant weight loss, even if their gradient, if their obstruction is still significant. Like I wouldn't be
Yes.
surprised.
I've seen it happen many, many times. Judy, we dropped that above, so we do have a checklist for you to do every year. It includes getting a new echo, discussing your echo and or MRI results with your physician and understanding your wall measurements, understanding your ejection fraction, knowing whether you're obstructed or non-obstructed, knowing whether there's been changes to your genetic information, meaning did we change something from being a variant of uncertain significance to benign or pathogenic? Have you talked about diet and exercise? Have you looked at your family screening project for the year? Who needs to get screened? So it's all right there in the checklist. and we try to make it easy for you. If you would like wasn't mailed to you, we can mail it to you. If you want to just download it, you can download it. We try to get them in all of our centers. They're going to get a package delivered next week, which is going to have their HCM Awareness Day party box, as well as some other resources. So you should be restocked at all your centers soon. So you'll be able to get that. Elan, I'm on Camzyos, cardiologist, Northwestern, put me on treadmill. Well, Alex, this one gets a little complicated. Why would somebody with obstructed HCM not need a treadmill test at this time? And what about monitors for people with and without devices?
So personally still put my patients that I actually talked about one today who still has some residual symptoms, even though they have no obstruction on their resting echo. And I'm pretty darn sure it's because they obstruct when they exercise. So there are indications to put someone on a treadmill, even though they're on mavacamten, to prove that they're not obstructed. And everyone should get on a treadmill at least once, if possible, to prove that. But my practice, and the guidelines suggest this too, at certain intervals, we should be doing some sort of functional exercise test, and in combining that with things that give us an idea of whether someone's heart is moving in the wrong direction. So there's a test called the cardiopulmonary exercise test, or a CPET, that I use to see is someone moving towards transplant or not, which sometimes you may not be aware of that, but there are objective data that we can get from these treadmill tests to tell you maybe you're not moving in the right direction, maybe you're moving in the wrong direction, or over the course of 10 years you've been moving. So it helps us kind of predict the direction someone's heading in. But, I personally have all my patients, if they can do it, if they can walk on a treadmill, I try and get them on a treadmill every 2 to 3 years, depending on patient factors, regardless of obstruction or non-obstruction. And then in terms of the monitors, so monitors, unless if you have an ICD, because you already were felt to have high risk and you needed an implantable device to protect you, or if you have something called an implantable loop recorder or a link monitor, which is a tiny monitor that goes under your skin that monitors you all the time, then some sort of rhythm monitoring should be done on a yearly basis. In our practice, that's how we do it. Now, different practices will do different lengths of monitoring, and the guidelines technically say, I think 2 days to 3 days worth of monitoring a year is enough. We tend to do 2 weeks because in our opinion, the longer you look, the higher likelihood you're going to find something that you need to address.
Yeah.
But we do yearly.
So let's just talk for just a moment on other reasons for somebody with an ICD still might need an event monitor
Totally.
periodically.
Yeah.
What would you do that?
ICDs are very good at protecting you from life-threatening things, at detecting life-threatening things, but there are thresholds that we set on both ICDs and on these implantable monitors to only detect certain abnormal heart rhythms above a certain threshold. Because, for instance, if you wanted the device to detect absolutely every single thing that ever happened in the patient, then it would just be information overload and it would drown out the really dangerous stuff. What happens quite commonly is my patients that have an ICD, they'll say, I don't feel good, Alex. I feel like I'm having a lot of palpitations. I feel really just sluggish all the time. And then you look at the ICD interrogation, and because of its conservative settings, it doesn't show anything concerning. Then you do a monitor and you find out that the patient's having 10%, 15% of their beats are all skip beats, like PVCs. Or they're having fast little runs of abnormal heart rhythms that are below the detection zone of the devices. Those are things that can be addressed, sometimes pretty easily. Like, maybe you're on mavacamten now and they stopped your medications that are good for palpitations. Maybe we should go back on a little bit of verapamil or a beta blocker or something to help calm those down. Maybe you have a lot of skip beats and we might want to talk about an ablation to get rid of that. There's a lot of things that can go under the radar because the devices are really made to save your life and to detect life-threatening things. But many, many times, the things we feel on a day-to-day basis are not the life-threatening ones.
And one of those would be atrial fibrillation.
Yeah.
And if there's AFib present,
Yeah.
even if it's low rates, it's something we should be monitoring for because you're then at stroke risk.
Yeah,
While
totally.
we talk about stroke risk, I'm going to go down another rabbit hole with you, and you don't have no idea what I'm talking about right now because we didn't pre-discuss this one.
Great.
So DOACs. Let's talk about DOACs for a minute. Alex, what's a DOAC?
So they've been called different things over the years. They used to be called NOACs. So you'll hear some people still use that term, but that was back when they were novel. So novel oral anticoagulation medications. But so these are medicines that it used to be that when you had risk for clots to build up in your body, and with HCM, we're mostly focusing on atrial fibrillation, an abnormal heart rhythm from the top chambers of your heart, allowing a clot to form in the top part of your heart that then puts you at risk for stroke. The other spot in your heart that can form clots is for our apical HCM patients. Sometimes at the tip of the heart, they can have a bulge called an aneurysm, and clots can form there. So those are like the two big populations in HCM that we think about need to be on some sort of medication to thin the blood to protect clots from forming. And it used to be that we used to have to use this old medicine called Coumadin that you had to monitor with
Rat
lab.
poison.
It is rat poison. University of Wisconsin discovered that. So that's why I think it's the Wisconsin Research Foundation is why warfarin is called that.
Oh, I didn't know that.
Yeah. And so that used to be all we had. Then years ago, like when I was in medical school, so somewhere in the 2010s-ish, they came out with these new drugs that's a pill that immediately can thin your blood and doesn't need to be monitored with labs. There's multiple different forms of the newer DOACs. And some are twice a day. So Eliquis or apixaban is twice a day. Xarelto, rivaroxaban is once a day. Dabigatran or Pradaxa is twice a day. Unfortunately, what you'll find from an insurance standpoint is that even though you might want to be on one or another, insurance companies will cover one and not cover others. I've run into this recently where with like with the Mark Cuban drug company, I was able to, my patients that can't get covered for Pradaxa or for Xarelto or for apixaban, I've been able to get them Pradaxa for like $30 for like 3 months or something through there. So there are options to take these medicines to thin your blood to protect you. And the reason we talk about them is because if you go into AFib, this abnormal rhythm, patients that have hypertrophic cardiomyopathy and AFib are at way higher risk from what we've seen than patients that don't have HCM and go into AFib. And so like the risk scores that we use in medicine to calculate someone's risk don't even really matter in HCM. There aren't scenarios really where if you have AFib and HCM that you shouldn't be on some sort of blood thinner, unless if you have tremendous bleeding risk, that then it becomes a risk benefit discussion. But these medicines are easier to take than the old blood thinners, and they protect you from stroke.
So they're great in so many ways. But one of the problems is you can't measure the coagulation rate right now. There's no method to do that. There's no lab test. However, there is an investigational device, and a friend of mine actually works for the company that's developing it, and HCMA is doing a little recruitment project for them. If you live in New York State, lower New York State, Long Island, or northern New Jersey, and you're on a DOAC, so it can be any of the DOACs, and you are interested in giving an hour of your time and a blood stick, maybe 2 if the first one doesn't work, but no more than 2, there is a new machine that they're hoping to get validated for bedside utilization that can measure clot time, so that if a person comes into the emergency room and they appear to be having an active stroke, but they're already on an anticoagulant, there's a period of time where you can't give them the antidote. You can't give them the therapy, the TPA for the stroke because they might bleed out because of the anticoagulation that they're on. But there's a way to measure whether they're at therapeutic level or when they enter a safer window. But this piece of equipment needs to be validated. So if you are in Northern New Jersey, Staten Island, New York, or by Cooperstown, New York, you can call us and we will connect you with there's being done in small doctor's offices. It's a blood draw and it measures how fast you clot. And the person who's created that technology also created the antidote for the DOACs, but we had no way to measure who needed them. The other thing that they're finding in this study is that maybe not everybody on a DOAC is at therapeutic level.
That's what I was going to ask you. I'd be interested to
15%
see.
right now look like they're not.
I'd be interested to see with my patients with on Xarelto, the daily one, if you did that at the, towards the end of their time,
Yeah.
right before they take the next dose, are they truly anticoagulated the whole time?
This tool, when validated, will be able to provide us the mechanism in which to test that to ensure that we are safe from start to finish. And as these DOACs come off of name brand and go to generic, which they're coming to the end of their IP now, when we have generic anticoagulants, we're really going to need to measure if they're working or not because we know the quality of generic drugs in general. So if you're in the area, if you know somebody on a DOAC, they don't have to have HCM in these areas, have them call us and we'll be more than happy to tell them where they can get involved in this project. We are being paid a stipend to help recruit for this, but it's a little baby project, but I think it's really important. I think we need this tool in the world, and if it works, great, and if it doesn't, we'll keep trying to get something that does do the job. But there's an opportunity for clinical trial for an hour of your day, and they'll pay you for your time. So call us if you're interested. Getting back to the other topic, and Hannah, who's on our team of navigators here, has a question for you, Alex. Are there alternatives to treadmills for people who can't tolerate a treadmill test?
Yeah. So some places have bikes, whether they're upright bikes or recumbent bikes. So that a lot of times the recumbent bike, so when you're laying flat and just your legs in the pedals and you kick, that can be a really good test. That's what I used to do when I was at Vanderbilt. So every different institution has their thing. We have a bike. We don't have a recumbent bike yet, but we have an upright bike. So for people that, it's really hard on their knees or some instability on the treadmill, the bikes or the recumbent bikes can be helpful.
I'm trying to remember where it was now. During one of the site visits I was on this past couple of months, a new kind of recumbent bike that was meant for stress echoes that was like so cool and it looks so comfortable.
Yeah.
I have to ask Stacy where that was. I forget which lab it was, but it's got this great dropout for the echo window as you're on the bike. It just made so much sense. I have absolutely no idea how much it costs or who makes it, but it made sense to me as a patient for when I was unable to be on a treadmill anymore before my transplant.
Yeah.
Can you talk a little bit about goal-directed Valsalva and how that can be helpful as well?
Just had a conversation with my sonographers about this yesterday. So goal-directed Valsalva is essentially when we have you guys do echoes, we want to make sure that we're not missing any of the obstruction of blood flow out of the heart. So we take pictures of your heart at rest, just when you're sitting there, to see is the blood flow out of the heart normal. Then when we have you Valsalva, which is we ask you usually either to bear down really hard. Sometimes they'll say bear down like you're having a bowel movement. Sometimes places will give you like a syringe to blow, to tell you just blow as hard as you can on the syringe. The goal there is to try and have you bear down enough so that it decreases return of blood from the bottom part of your body into your heart. And anything that underfills that left side of your heart can make your obstruction worse. The problem is there's obviously a lot of variability when you ask somebody to bear down. Like some people are going to go and bear down as hard as they can. Other people are going to and not too much at all. And so then the idea was, and I think Matt Martinez might have been one of the people that pioneered this. What if you have someone blow into a flexible tube that's hooked up to a blood pressure cuff and tell them, I want you to blow up and generate 40 millimeters mercury of pressure. That gives them a goal that they have to achieve and blow as hard as they can until they hit that number. Are you going to get more reproducible results? And in the papers that have come out from their group, and Dermot Phelan down in North Carolina also had a paper on this, they've been able to bring out obstruction in some instances where patients, they would have missed it otherwise because the patients really did a good Valsalva. So I actually just did a pilot in our lab with this to see if we were going to integrate it. And the feedback from patients was mixed. So if any of my patients are in here right now, I'd love to hear whether you didn't like it or not. Some patients felt like it made the studies too long and it was too hard to do, and they were frustrated with doing it. Other people didn't mind. In my opinion, I think it can be very helpful when I'm almost certain you have some obstruction and we're just not seeing it at rest, because it's a really good stressor to bring out obstruction.
I had the opportunity to participate in a group training exercise at the American Society of Echo. We brought in HCM patients, and they had some models there who didn't have HCM, and we allowed people to do echoes on real patients with HCM. It's really fun because they start the day and they have really low gradients, and they don't get enough water throughout the day, so their gradients go up, and you see the effects of dehydration throughout the day, which is kind of interesting. But we sat and we watched a number of these patients do the goal-directed Valsalvas and how much more consistent the readings were. So there are times where I say nicely and with a little bit of grace, suck it up, buttercup, do the test this way because it's going to be more reproducible. It's not that difficult to do. It's not comfortable, but it's not uncomfortable.
Yeah.
It's a little awkward, I guess is the right word.
Yeah. It's pretty much the only way you can guarantee that all of your patients are putting in the same amount of effort.
And if you want to know how you compare to your peers and when to make decisions on, yes, I want this med, or yes, I want this surgery, the numbers being consistent can really help you in your decision making.
Yeah. And it can also be the difference between you having to stop mavacamten or not. Like it can have an impact on that.
Absolutely. Next question. So we're in question mode and we've got another about 5-7 minutes here. This is an interesting question, Sherry, and thank you for asking it, because you're asking a good question. Do you still need an MRI every 3 years after you had a septal myectomy? Dr. Feria, what are we looking for in an MRI and why do we repeat them?
So the septal myectomy, and there is differing opinions on what the long-term outcomes are after doing a myectomy. And there's some data and some people that believe that once you get a myectomy, you're put on the same trajectory as the general US population and you're going to live a super long life and nothing ever is going to happen to you. There's other data that suggests that, you still can have all of the complications of HCM that are not due to obstruction, which to me makes more sense. And so a septal myectomy is removing tissue to relieve blood flow out of the heart. So do not be surprised if you get another MRI if the measurements of thickness in one specific area where they did their resection are smaller. But myectomies do not get rid of scar. If anything, you're cutting out muscle and creating scar where you made the cut. And so the idea behind MRIs is for patients that have not met the threshold to need an implantable device. One of the reasons we continue to reassess with MRIs is to look for progression of scar in the heart. And so a myectomy would not change that. There's other things we look for too, like MRIs actually are more accurate for measuring the squeeze of the heart than echo. So that brings up another point. It's very common that the ejection fraction or the squeeze on an MRI is going to be lower than what your echocardiogram measures. Like many patients will get an echo and it'll say their EF is 60, and then they'll get an MRI a month later and it says their EF is 50. And that doesn't necessarily mean that your EF dropped 10 points. It's a difference in how we look at the squeeze of the heart. So just keep that in mind. Talk to your cardiologist. There can be instances where the squeeze goes down, but many of those times, there's no difference in how the heart's squeezing. It's just a difference in how we measure it. And it probably reflects that we're overestimating the squeeze on echo when it's really probably a little bit lower. But yes, to answer your question, you should be getting the MRIs if you don't have a device. There's a certain point where, let's say you reach your 70s, 80s, and you're like, the likelihood, if you've never had any other risk at all, and you're not having abnormal rhythms, that your likelihood of having a life-threatening event is probably so low that then we say, okay, maybe we don't need to continue to do the MRIs. But that there's a lot of patient individualistic factors there that go into that. But if you're still concerned about risk, MRIs can be helpful to adjudicate that risk.
Okay, so devices. So some devices you can still have an MRI, some you can't. However, if you've got the device in place, you're going to get shadowing and dropout from the image from the noise that the can or the generator
Yeah.
and the leads can create. So we still can use them in some patients with devices, but not quite as accurate.
Yeah. Sometimes the subcutaneous ICDs that sit on the side of the body can make it easier to see the heart, but definitely the transvenous ICDs that sit up here in the chest, the metal from those can cause an artifact that makes it very hard to see the heart. Now, we do different sequences on MRI to try and get around that artifact, and you can still get MRIs, but you have to talk to your electrophysiologist before you do that, because there's some reprogramming of the devices and things that have to happen. And so they can be used. They're just, the MRI image quality is not as good once you have a device.
Okay, question again. So we did this one a little bit earlier, Judy, but we'll just rephrase it for you. There's more reproducibility when you're using a standardized goal rather than a self-directed goal, because we're all different, and on a different day you might give a different effort. I don't know, but like if you show up and you're having a bad stomach day and they tell you to bear down, do you really want to give it all you got on the table that day?
Yeah.
You might leave a little bit more behind than you thought.
Yeah,
So
we just did the pilot at our center, so I can't give you specific numbers, but there are definitely some patients who the goal-directed Valsalva either showed severe obstruction when we would have missed it otherwise, or they were on mavacamten, and these were all mavacamten patients that got the goal-directed Valsalva. There were a few patients that would have had gradients below a threshold that we would have had to, by protocol, stop the drug or lower the dose. That when we did goal-directed Valsalva, it increased the gradient enough so that we didn't actually have to decrease the dose of their medication. So it did make a difference in a handful of patients. It's probably most beneficial in places that don't do a lot of HCM echoes, because part of it is also on the sonographer who's doing it to really push you to do the Valsalva.
and some are going to use soft techniques, and some of them are going to
really
come
make
at you a little harder. So
yeah.
if you do goal directed,
You standardize it. You take it out of the hands of the technician.
Excuse me, I did bring water. I thought this was yesterday's water. Sorry about that, guys. Another question came up about the list, and we call it our rack card, because that's what it was ordered under. I don't know why. But this is the list that you're looking for, Elon. So you can pull that at any time from the website. So it has been created and it should be in your doctor's office. What about those who have an allergy to gadolinium, or a sensitivity to gadolinium?
To be honest, I don't think I've ever run into someone with a true gadolinium. I think one thing that can be confused is there are plenty of patients with contrast allergies. Contrast can be iodine-based contrast, like what you think for CT scans. We also use the term contrast for gadolinium-based contrast for MRI. If there is a concern, at least at Penn, depending on what the allergy is, we do have a pre-treatment protocol where you get some level of antihistamine and steroid dosing a certain numbers of hours before getting the contrast load that can help get you through it. But it depends on what, like if it's anaphylaxis, like if it's really severe, then sometimes there aren't workarounds. But if it's like a small rash or mild hives, sometimes you can get around it by pre-treating. I think it just depends on what the allergy is.
Yeah, I would check with your allergies. I had sensitivity to some contrast agents back in the 90s, and they're like, "Oh, we don't use that stuff anymore." I'm like, "Okay." So, I'm not quite sure what all my records are on that. I haven't thought about it in a while, but if you have allergies or sensitivities, you work with the team and they'll work around it. I do know people who have had the pre-medication regimen before. You wanna get somebody to drive you home because 'cause you're kinda loopy after that one. Okay. Couple other announcements as we wrap up. So throw in your questions now. We've got about another 4 or 5 minutes maybe. Um, Number one, as we come into HCM Awareness Day, if you are interested in using our frame for your social media profiles, you can email us your photo and we can drop them into a frame for you and we can send them back. So you can send those to Demi, DEMI, at 4hcm.org, and she will start working on those with some of our volunteers. So we've got that one coming up. If you are interested, and I only have like 30 of these to go to the public. So every one of our centers of excellence is getting a party box for HCM Awareness Day. And in that box, there's going to be a photo wall. So there's a poster so you can take pictures in front of yourself. We've got some awareness bracelets. We've got some QR code tent cards so people can get more information. And of course, some of our materials for distribution. If you wanna have a house party, if you wanna bring it to your place of work, email us, "I want a party box," and you can email that to support@4hcm.org. All of our centers will be getting one for the first week of, February, and, we hope that you can run your events on HCM Awareness Day or that week and send us photos and send lots of pictures. If you wanna do it in honor of somebody, in memory of somebody, this is a great opportunity to talk about your why and why it's so important for people to understand that HCM is common so we can get to these families in time. I'm seeing a message pop up here that I think is appropriate, as I mentioned, having somebody, having a memorial for somebody. I'm so sorry that you lost your son back in 22 at the age of 16. And I'm not surprised to hear he wasn't diagnosed yet. Um, and that does come with survivor guilt and a lot of other things. And yes, you're probably overthinking, but there are things that we can do to help amplify his story to ensure that others don't go down the same path. And that is getting involved with our legislative initiatives at the state level to ensure that every child has the opportunity to discuss with their own physician the family heart health history and the child's independent symptoms, and ensuring that the doctors are looking for the risk profiles that might exist in families who have genetic heart diseases that run through generations. Now, there's always going to be the first one who makes everybody aware, but we typically have a way of looking back in the family tree to make sure that there's nothing else that we're missing. But unless we're asked, we don't tend to go back through the family tree because we may not know the people that were lost, and we may not know the family stories if we don't talk about it. We've created a children's activity book based on this so families can work together with their younger children to think about their family heart health history, because what better gift can a parent give their child than the knowledge of how to protect themselves in the world? And if there's a heart risk, we want to know it's there and we want to be able to look for it. So, my sincere condolences for your loss. We are here to talk to you about what you can do to get involved and to share his story and to make sure that it's a cautionary tale that will help others. So please call the office at 973-983-7429. Schedule an intake. We'll get you hooked up with our legislative team and we can share that story and let your son's face shine through HCM Awareness Day. Well, we'd be happy to, give you the framing and the talking points and maybe even get you involved in one of our state legislative briefings if it's a state that you live in. So please do call the office and we're more than happy to elevate your son's story. Excuse me. Okay. One more question, please. Okay. Last question. I think you mean mavacamten. Is it possible to reduce the need for septal myectomy if I had endocarditis? Oh, we're just throwing some red herrings in that story. Alex, MAVA, HCM, endocarditis.
So if you remove the endocarditis part of it for a second and just say, does mavacamten reduce the need for septal reduction therapy? There was a trial that tried to get at this question called the Valor HCM trial that took people that had symptoms and severe obstruction and met criteria for myectomy. What if you randomized them to placebo versus mavacamten, and then at some point in the trial say, hey, guess what? You were on mavacamten or placebo. If you're on placebo, do you want to try mavacamten? Long story short, the overwhelming majority of patients that were on mavacamten either from the beginning or were transitioned onto it after they had been on placebo either did not meet criteria to proceed clinically with surgery, which means their symptoms improved and their gradients went down, or they didn't want to proceed with surgery. So there is good data to suggest that many patients can be treated adequately with a myosin inhibitor like mavacamten and not need to have surgery. The endocarditis part of it is, I would honestly have to look at your chart and look at your heart to know what the long-lasting effects of the endocarditis was on your heart and why is it that you have obstruction. Because if it was that you had endocarditis and it damaged your mitral valve significantly, which tends to be with HCM patients what gets affected, because that valve is involved in the issues that cause obstruction. So over time, that valve becomes abnormal. It's one of the reasons why I still tell all of my patients, and I myself take antibiotics before getting dental procedures, is because those valves are abnormal. There was time, and there's still many doctors that don't do antibiotics, but I do. So if that valve is very abnormal and it's a primary valve issue that's causing your obstruction, that might be an instance where mavacamten might not be enough to fix obstruction. You actually might need surgery. Or if there are more issues on top of obstruction, like is the valve really leaky just because the valve is damaged and some of your symptoms are due to leakiness of the valve, that would be a surgical issue, not a mavacamten issue as well. So you should sit down, your cardiologist should put your echo up in front of you and show you what your heart looks like and why you have the issues you're having. And then it should be clear to you whether mavacamten is a good choice or if you actually need surgery. And it would, in that instance, probably be a myectomy plus some sort of intervention on your valve.
Mary Lou, I would ask you to call the office and set up an intake and navigation call, and we can get into this a little bit more specifically and help you prepare for that conversation with your physician. What can happen to a valve after endocarditis can be rather complicated. And I had endocarditis 35 years ago. I did get to keep my valve until I transplanted my heart. So I don't know what role the endocarditis played in my eventual need for a transplant, if any. But endocarditis is not fun. On that note, I am a few minutes late to a meeting. Alex, this is a wrap on episode 200 of Tales from the Heart.
Thank you.
So I love that it's Dr. Patient meeting a milestone number for our events. So thank you for joining us, Alex. Thank you for all the questions today. This is a great conversation. I hope you're ready for next year with your HCM. Hang in there. Let's pass some laws on making sure our kids are being tested and screened for cardiac risk. Let's get involved in helping our healthcare systems survive. And let's talk about real solutions. Join us on Tales from the Heart, Deconstructing Healthcare, to understand the basis of the U.S. healthcare system and how we might be able to engage with it in the future to help change the trajectory of where it's going, because it's not necessarily serving patients so well right now. So join us for those conversations. If you have not called for an intake and navigation call, now's the time to do it. Our patient registry is open and we're consenting patients into that registry. And this is your opportunity to use your lived experience to help other patients down the road understand their HCM better by all participating jointly in this new registry. So stay tuned for more information on that and join us tomorrow at 11 a.m. Eastern for Tales from the Heart, where we will be talking all things genetic therapies related to HCM. Alex, thanks so much. Go have a great day and go take care of all those patients.
Will do. Thank you.
Thanks, guys. Bye-bye. 200, it's a wrap.